Hello, and the greeting uh, and welcome to the second case of our forum. And this is Dr. Bhaumik, uh, pediatric endocrinologist, University of South Alabama, and retired colonel of United States Air Force. At present time, I also retired from University of South Alabama, and I was I was very intimately involved with the board review course offered by LSU at New Orleans, Louisiana. Today, I'm going to discuss a very interesting case for you. And this is a 16 years old male who came to see you for bilateral breast enlargement. And he's a tall boy, not overweight, and he has otherwise been healthy. And the breast enlargement has been noted for about past 2 years. So, what is your diagnosis just by looking at this? Who just listening to this history? And what is the important physical examination, and what investigation, and what additional comment, depending upon what we find. The differential diagnosis, could it be a physiological gynecomastia? Of course, it could be, because about 30 to 40% of the boys, as they go through the adolescent, may have gynecomastia, and different series give a different number, but they resolve over the period of time. And sometime, if they have obese, it could be really persistent and could make uh, a tremendous psychological problem, especially in African Americans. So physiological gynecomastia cannot be ruled out. But could it be an organic gynecomastia? Well, that you need to think about it, because organic cause most common will be your medication, drugs, and recreational drugs like marijuana is really top on the list. So that history has to be often analyzed quickly. Further physical examination will give you further information, and does show that he is on 80th percentile in terms of his height and 60th percentile in terms of his weight. Arm span is a little bit more than the height, 182 centimeter, and he appears to have long legs. The phallus is appropriate. Our test is 8 ml by volume. Pubic hair is early Terra 3. There is no facial or axillary hair. And as you can see clearly that there is a gynecomastia, breast development on this side, and he seems to be pretty healthy, very muscular, so we cannot blame obesity. So it's pretty muscular boy. However, by looking at him and his phallus development, his testicular volume was 8 ml. Okay, this is important diagram, uh, or this is called orchidometer, and this color suggests prepubertal testicle. And from 4, you see the changes of the color. And so this is how I remember the 4 is for puberty. So 4 ml of testicular volume suggests very early puberty. So 4 is for puberty, and his has gone up to 8. But for his size, the way he looked like, that appears to be rather small testicular volume. And the 12 is the one where actually you start having a spermatogenesis, and 10 where you get the pubertal growth spurt. Just a little bit something to remember. So based on the physical diagnosis, physical finding examination, what is your diagnosis? So important finding in this physical examination is he's a tall boy, he has long leg, he has increased arm span, and he is not overweight. and his testicular volume is small and less pubic hair and has bilateral gynecomastia. Right is a little bit more than the left, which is not uncommon. So his diagnosis is clinically is Klinefelter syndrome. Klinefelter syndrome is the most common chromosomal abnormalities that's seen in man. And actually, the incident could be as low as 1 in 1,000. On the other hand, Turner syndrome is the most common chromosomal anomaly you see in Turner, which is about 1 in 3,000. So Klinefelter is more common than Turner syndrome, and it affects the Turner syndrome affect the girls. So karyotype is 70% of the cases is 47 XXY. About 30% of the cases it could be mosaic. The mosaics are the one who is difficult to diagnose and they look normal, and even some of them could be fertile. Other lab that you do will show in Klinefelters increase FSH and LIs, however decrease testosterone. The smallest testicle is one of the classical findings of the Turner syndrome in Klinefelter syndrome, and this is secondary to hyalinization and the fibrosis of seminiferous tubules, and which lead to the oligospermia, azoospermia, and typical those who have classical Klinefelters and they are infertile, and many of them is going to need testosterone injection to go through puberty. The commenter Turner syndrome is usually diagnosed as puberty because they don't have any uh, dysmorphic features that you will see, and many a times they may have, if you retrospectively go back and start looking at them or get some more history, they may have behavior problem, somewhat delayed psychosocial problem, and motor development. But those are like, if you go back and start asking them. Is another interesting thing that is your board question, that this is where breast cancer has a higher incident in inorganic gynecomastia or physiological gynecomastia. You don't see breast cancer, but in KFS, you have they have higher incident of breast cancer, and as a result of that, they should be followed very carefully. But a prophylactic mastectomy is not routinely recommended. However, there are some people very aggressive, they have done that, but that's very, very rare. They have higher incidence of autoimmune thyroiditis, rheumatoid arthritis, and adult onset diabetes. Uh, they also have higher incidence of lung cancer uh, and the other autoimmune disease as well.